Good afternoon, everyone. Greetings and welcome to today's MHA Alumni webinar, Health System Specialty Pharmacy, Opportunities and Challenges. I'm Pete Engler with the MHA Alumni Association Education and Engagement Committee. Thank you to all alumni, students, and friends of the MHA program who have made time to join us live today. Today's webinar is hosted by the MHA Alumni Association and was planned by the MHA Education and Engagement Committee. We're excited to offer this webinar to encourage and provide lifelong learning to both local and distance alumni, and we plan to offer more webinars in the future as part of an ongoing series. Before we get started, we'd like to go over a few items so you know how to participate in today's event. If you join the presentation listening using your computer speaker system and you would prefer to listen over the telephone, just select the unmute button at the bottom left of your screen and select Switch to Phone Audio. If you experience audio difficulties while listening via your computer speakers, this can be caused by having multiple software applications open, which can use up your computer's bandwidth and affect network performance. Listening in on a wireless signal may affect performance as well. Feel free to close any unnecessary applications on your computer. Questions are welcome throughout the webinar today, and you may submit them at any time. Please type in your questions by clicking on Q&A button at the bottom of your screen. You should see a pop-up screen where you can type your question. We'll be monitoring questions along the way, so please submit your questions or comments at any time. And now for our webinar on specialty pharmacy. To start, I'd like to introduce the presenter of this webinar, Kyle Skiermont. Kyle is the Chief Operating Officer for Fairview Pharmacy Services, a leading health system-based pharmacy organization in Minneapolis, Minnesota. He received his PharmD from the University of Nebraska Medical Center, College of Pharmacy. As COO, Kyle is responsible for strategy and overall operations of Fairview Pharmacy Specialty Pharmacy, Retail, MTM, Mail Order, Long-Term Care, Compounding, Home Infusion, and Community Infusion business units. Kyle has spent 20+ years in pharmacy, including traditional retail, clinic-based retail, outpatient pharmacy at an academic health center, community and home infusion, specialty, and mail order. Welcome, Kyle. We'll turn the webinar over to you at this time.
All right, great. Thank you for the introduction, and thank you for inviting me to present to the group today. A topic that hopefully people can tell from my introduction is near and dear to my heart. I've spent a lot of time here at Fairview on this topic, but as the introduction stated, have also had the opportunity to work with, gosh, we've probably worked with 30 to 35 at least other health systems across the country around their specialty pharmacy strategies, everywhere from just being kind of their phone a friend to help them get up and started, to actually putting boots on the ground and working side by side with a handful of health systems to help them get up and going. To give you a little more background on Fairview Specialty Pharmacy, just so you've got a little bit of perspective of where I'm coming from, we are the nation's largest health system-owned specialty pharmacy. We'll do probably about $650 to $700 million in revenue this year for people who think that way, or we take care of about 10,000 patients at any given time through the specialty pharmacy for people who think more in kind of those metrics or those types of numbers. So what I was really hoping to cover with you today, especially if I can get the slides to advance, there we go, is really I wanted to start off with kind of the key parts of the business decision for a hospital or a health system thinking about specialty pharmacy. So really trying to get into kind of the why to get in, or potentially, quite honestly, why you might not want to get into the specialty pharmacy marketplace or the specialty pharmacy business. Then obviously from the title, talk through some of the opportunities and challenges that happen for a health system specialty pharmacy. And I think some of these are unique to the health system space, and some are not. Some are just challenges and or opportunities more broadly in the specialty pharmacy market. And I'll try to kind of denote where those are something that are specific to a health system versus, really would be a challenge for, a mom and pop specialty pharmacy trying to get into the business. And then the last thing that I added in was to have a little bit of a discussion around data. And I think it's important just because it's such an important element on anywhere from deciding if you're going to get into the business to making the business successful to just kind of the ongoing relationship with the various stakeholders in the specialty pharmacy market. But I thought it was important to touch on this area. And throughout, I'll hit on topics like limited distribution drugs. We'll talk about 340B. I'll kind of hit on a lot of the different areas that, again, while bigger than specialty pharmacy, definitely have big impacts in the specialty pharmacy world. So I think to start off, really, and this first concept is really probably more broad to pharmacy or just kind of pharmacy globally in a hospital or health system, but magnifies itself when you think about specialty pharmacy. And really it's this idea of health systems spend a lot of time and energy, a lot of resources on really trying to keep things inside of the health system wherever possible. So if you think about a cancer diagnosis or an oncology diagnosis, if it's a primary care physician within that health system, they're going to do everything they can to refer that patient and that patient's treatment to an oncologist that is related to or employed by the health system itself, right? They want that to stay inside of the health system or inside of their capabilities. And that same thing happens if a patient needs to be admitted or needs a higher level of care. It's very rare that a health system is going to, willingly send that person off to another facility or to another health system. They're generally going to bring them into one of their owned or, again, affiliated buildings. But when it comes to pharmacy, this isn't the norm nationally. And I think somewhat in the Minnesota market, because, I know probably a lot of participants are from the Minnesota market, this is a little bit different, or it's a little bit more common that the hospital or health systems here in Minnesota have some pharmacy capabilities. But generally in a health system, this is not a capability that they possess. And so when you think about a prescription being written, and that can be, as I was saying, this is really globally pharmacy. So this could be anything from a antihypertensive medication all the way to an oncology, just to continue to play out that example. That prescription is generally going to be sent to an outside pharmacy. So the dollars and cents from that prescription are flowing out. But I think even more importantly, the clinical care of that patient is flowing outside of the system. And so that can lead to fragmentation of care and kind of breaking up that care continuity for a patient for what is oftentimes, when you're talking about a specialty patient, the definitive treatment for them is the medication that they're taking. And so what this really means then for health systems in a broad picture, again, kind of bringing it more specifically back to specialty, is, and you can see some of the statistics here on the slide, but specialty pharmacy is projected to be the third biggest cost in healthcare by 2020, right? And that's already next year. I think a lot of health systems and also a lot of health plans and a lot of employers that we talk to would say they're already there. And so as the market is moving more and more towards total cost of care arrangements and looking at value-based payments or ACO-like, right, they're known by a lot of different names. But as that is becoming more and more common, and that's becoming more and more the way healthcare is being paid for, not having control over or not having an ability to influence these costs and these very, very sick patients is becoming more important. And that really kind of dovetails into the second bullet point of this idea of if you're outsourcing or kind of sending to a third-party pharmacy, you're really not able to control the cost, which I've been speaking about, but it's also the quality. So these are patients who are oftentimes, it's 1 to 3% of the population generally, if you think about specialty, but they're oftentimes also going to be your most expensive patients and, quite honestly, some of the most clinically complex and sickest patients. And I think one thing I want to just make sure to maybe level set. So when I'm talking about specialty pharmacy, this is different than sometimes in a broader medical sense where orthopedics, for example, might be considered a specialty area, or OB might be considered a specialty area. And there are some medications in kind of the specialty pharmacy world that might be put into that category. But really, I mean, I think for this discussion, you could almost equate specialty pharmacy to highly expensive medications. In the past, they were things, oftentimes they were biologics, a lot of times they required refrigeration or other kind of special handling. But really, specialty pharmacy has come to be defined by health plans and PBMs. It's really the payer who's kind of determining what is specialty versus what isn't. And I always think a good example of, if some of the insulins that are out today, came out, today, and insulin wasn't something that had been around for a long time, insulin would probably be considered a specialty pharmacy drug just because some of the costs. But generally, you're talking about things like a lot of your GI medications, rheumatoid arthritis, MS, CF, oncology, just to give you a sense of those are some of the categories of medications that fall into this bucket. And so with that, again, this kind of the lack of control or lack of ability to have a clinical impact on these patients can oftentimes be a huge challenge for a health system. And then ultimately, kind of the fourth bullet point there is really getting at the fact of there's definitely clinical implications and quality implications for this, but there's also dollars and cents implications towards or for specialty pharmacy for a health system. Oftentimes, even a mid-sized health system will have hundreds of millions of dollar opportunity from a revenue perspective to get into specialty pharmacy or prescriptions that are being written within their health system. And in particular, if that health system has 340B eligible entities, that can also drive substantial, an attractive financial model because not only is it driving top line revenue, but it can also be driving net income to be reinvested into the health system as well. And so at a high level, and this is probably the highest level, and we'll obviously get into more of the specifics, when you think about specialty pharmacy, maybe compared to something like traditional retail pharmacy that a lot of people are familiar with, kind of going to the corner drugstore, a Walgreens or a CVS. Some of the opportunities that we see in specialty are that it's a very, very high revenue and it's revenue that's growing. So in a lot of areas of pharmacy, we're seeing fairly flat growth over the last year or two, really where the increase, and even in the lay press, you hear a lot about the rising cost of drugs. It's generally happening in specialty pharmacy. And so while this is a challenge for us or a problem for us, if we think about our inpatient or our acute care stays, from a self-administered or an outpatient ambulatory perspective, this is actually a diversification of revenue opportunity for most health systems. One of the other kind of high-level opportunities for specialty, and again, different than some of the other types of pharmacy, is you have a concentrated number of patients and providers. And why this is an opportunity is because different than having to compete with a Walgreens, for example, that might have a store on every corner and everybody's kind of familiar with what happens at a normal pharmacy. With these concentrated patients and providers, you can really concentrate your efforts on differentiating yourself as a specialty pharmacy, or even just really connecting with those patients and providers to tell them about the types of services that you're offering. Two of probably the biggest challenges that happen from a specialty pharmacy perspective, again, kind of at that 50,000-foot level, are obtaining contracts to be able to provide the services. And I'll talk about this more throughout the course of the remaining 45-ish minutes. But this is a very, very concentrated market. And so what I mean by that is all of the major pharmacy benefit management companies own their own specialty pharmacy. And depending on the stats that you look at, somewhere between 2/3 and 3/4 of all of the specialty pharmacy orders or prescriptions that are filled in the United States are filled by 4 providers. And so as you can imagine, with that concentration, they're well-funded, they're decent at what they do as far as kind of getting the message out and they're not looking to give this up because it is such a growing area, whether you look at it as a revenue perspective or a cost perspective. And so different than a lot of other areas of pharmacy where you can just open a pharmacy and start to service patients, in the specialty world, you really have to have contracts with a health plan or with a PBM in order to be able to even service these patients. And as I said, I'll talk a little bit more about some of the strategies for unlocking those possibilities. And so when I look at the different things to look at or ways to assess if a health system should get into specialty pharmacy, it really, from my perspective, it's not a lot different than any other business that a hospital or a health system may be looking at. So it's not any different than if they're going to expand clinical services or if they're going to decide to, to kind of build a new tower of the hospital. The basics of what you would look at are the same. And I'll talk about some of why in specialty pharmacy the specifics are a little bit different. But again, no different than any other business line. The first thing to do is to really decide, why do we want to get into this market? And this is, I think, so fundamental, and in my work, we've seen so many health systems kind of start and stop or have challenges when they look at specialty pharmacy as an opportunity, because they haven't really decided why they're getting into it. And so what I mean by that is, right, there's a lot of reasons to get into specialty pharmacy. I think most of them land in kind of two big buckets. One is the financial opportunity, right? So both a top line and bottom line opportunity. And the second is really kind of clinical care or the quality of care, continuity of care for the patients of the health system. And I think most people listening would probably say, well, you'd want to do it for both, right? And I would say the same thing for, in my position and at Fairview, ideally you want to do both. But I do think it's very important early on for the health system to really decide which of those two big buckets are really the driver. Because I think the reality is you will make decisions in some of the areas downstream differently based on if the true reason for getting in is as an economic opportunity, or if the true reason for getting in is more of a clinical opportunity. And that doesn't mean that if you're getting in for financial reasons, there won't be clinical benefits, or vice versa, that if the real reason to get in is clinical benefits, that there aren't still potentially economic benefits. But I do think it's important to really decide which of those two is the driving force for the reason to get in. And then the second one, again, no different than other business opportunities, is really kind of educating and getting key leaders on board. This can't be something that is just driven by the pharmacy department. This has to be a health system-wide or an organizational-wide strategy and an organizational-wide all hands on deck to make it happen. And I hope as I go through some things you'll understand why. The last three I'll talk a little bit more in depth, but the idea of really sizing the opportunity, kind of what's there for you from both patient numbers and finances, and then the gap analysis, what services do you already have versus what might you need to develop, and then ultimately then it's identifying from that gap analysis what are the resources needed and identifying, can you go out and get those resources, what are the costs going to be associated with those resources. And so quickly, just to add a little bit more to the sizing the opportunity, really with this, the gold standard is going to be if you can pull your electronic medical record data and actually see the number of prescriptions or the number of orders for these types of medications that are being written. I mean, that's the best way to get it, because then you're making a lot less assumptions, you're using a lot less kind of extrapolations if you've got that. But that's oftentimes challenging for people. They may not have been on their electronic medical record for a long time. They may not have a sophisticated IT group that can pull that out. And so there are different ways to do it. You can look at market data. So oncology, for example, most health systems will know what their market share of oncology is. And so there's ways to kind of back into the number. If you're servicing a population of 1 million people and you have 20% of the market, all of a sudden you can start to kind of back into the likely number of patients that you would have to service. And then there's also, this is one of the first areas where I'll mention this, there's a ton of consultants in the space. There are companies out there who will actually help you open your specialty pharmacy all the way from beginning to end. The major wholesalers that sell pharmaceuticals to the health systems have arms that will do this. There's no lack of, I think, consultants in the marketplace that can get you pretty good information on what your sizing will be. I think the next big thing then is, once you've got that prescription count, is the idea of a payer analysis. So what does your payer market look like? So just a couple of quick pieces of advice, or a couple of nuggets maybe here, is if you've got really, really good relationships with your payers, you're much more likely to get into those contracts, which I was talking about a couple of slides previous, and actually have a fighting chance of being in the network to be able to fill for patients. It's also important to look at what your government mix is going to be, because those oftentimes, while maybe not your best payer, oftentimes have much, much more open access as a new provider coming in to gain access to those. And I think also what we have found is markets that tend to have more kind of regional and local payers versus a high concentration or a high proportion of the national players. Again, generally you've got a better shot, and not in every market, but most markets, if you've got kind of that local regional dominant payers, you've got a little bit better chance of having a conversation with them and getting into their network. And then just the last thing, is the 340B analysis, if your health system has covered entities that would qualify. And this is probably the first time I'll mention 340B, but it so fundamentally changes the economics of specialty pharmacy, or really any outpatient pharmacy, that depending on 340B and if you qualify and which medications qualify, can oftentimes flip the decision, at least economically, if it makes sense to get in. And it's not just as easy as deciding, do we have 340B or do we not? It's also for the types of prescribers. So for your rheumatologist, for your oncologist, what is their relationship with your 340B covered entity? Do they practice at that entity, or are they in freestanding clinics? All of that is going to be very, very important. As I said, I know we've talked to a number of hospitals and health systems that the initial analysis looked great. It looked like they had a ton of financial opportunity. And as we really started to kind of peel back the layers and see which providers sat kind of inside of the hospital versus outside of the hospital, it can very dramatically swing that pretty quickly. And so this is something we belong to a network of health system-owned specialty pharmacies called Accelera. This was a slide that I borrowed from them because I think it really kind of hits at this when you're sizing the opportunity, what things can look like. And what you start to see is how even if you have, let's say your health system has 10,000 specialty patients, ultimately that's not going to really be what your opportunity is, because you're going to have things that kind of start to siphon off or leak out patients. And so the first thing is just, does the health system have the kind of all the relevant clinical programs or all the relevant specialists? So for example, if you have no rheumatologists in your health system, you're probably not going to have a big rheumatology opportunity, in specialty pharmacy. Does the health system have the capabilities to run the specialty pharmacy? We'll talk a little bit more about that. Oftentimes they don't, or they don't have the right, and so that will leak out another handful of patients. And then this idea of, do you have the contracts with the payers? If not, again, more patients will be funneled away. And then to a smaller extent, a number of medications in the specialty pharmacy space are what are known as limited distribution drugs, which basically just means there's only a small handful of pharmacies that can even get the medication to dispense or to get to patients. And so oftentimes that's another limitation for health systems. And so another way to look at this would be, so this would be looking at a pharmacy that's got about a $350, I think it's $360 million opportunity in specialty pharmacy. They're probably doing some of it now. Maybe if they have a discharge pharmacy, or if they've got an oncology pharmacy, they might be getting some. The reality here, what I'm trying to illustrate here, is even if your total opportunity is as high as what this is purporting to be, the reality is you're not going to capture all of that. Kind of, if you think about that funnel that I showed, a number of those prescriptions are going to leak out. Even if you've got the best clinical programs in the world, even if you've got your providers on board, it won't matter. Those will still kind of leak out of the system. All right, and so then the next big area after doing the sizing is kind of that gap analysis. So, right, it's the basic of basic business propositions of, do you have the right people? Do you have the right processes and workflows? And then do you have the right tools, whether that be technology, hard capital assets, brick and mortar, just kind of the things that you need to run the pharmacy. And again, there's a handful of ways to kind of accomplish that gap analysis. There's always consultants out there, the same ones that I mentioned earlier, that can come in and do it. But some of the other ways here are, you can actually do some surveys of patients or providers that utilize these services. probably not the best strategy to kind of get something up and going, but if you're looking at some niche areas, or if you're looking at maybe once you're up and going how to improve, this can be a key area to go actually talk to the utilizers of the service and find out if there are gaps or if there are certain things that you could be providing that would differentiate yourself. Other things that you can do is look at whether they're limited payer or limited distribution drug RFPs that may be out there. Oftentimes by the questions that those RFPs are asking, you can get a sense for what the market is expecting of a specialty pharmacy. And then another area is most specialty pharmacies will need to have an accreditation by an outside body. So that's another way to look at it, is to get one of the accreditation manuals and really use it as a checklist to basically say, are these all things that we can do and we're ready to take on, or which of these things are things that we currently aren't capable of, or we would need to bring in new talent or new processes, new tools in order to do those, has been an area that a number of people have found to be successful for kind of figuring out if they've got the right things. All right, so I wanted to touch a little bit on, at the very beginning I talked about some of the things that make specialty pharmacy a little bit different, and kind of talked about a lot of it is cost. But the services that are expected by the various stakeholders really are different than kind of your traditional pharmacy or pharmacy that you might be thinking of. And the first big one is really probably the distribution of the product or the distribution of the medication to the patient. Rarely is this face-to-face in the current world now. It's generally done by mail order or home delivery, where the patient is going to get an order from the provider. It's generally going to be sent off to a specialty pharmacy. They're going to do the work that they need on it, and they're going to send it to the patient. And so there's the need for expertise just in those, kind of the logistics of distribution to patients that might be far-reaching. But in particular, with a lot of these specialty medications, they're refrigerated medications, and so cold chain expertise also becomes something that's required for specialty pharmacies, and not just can we buy a cooler and put an ice pack in it, but how are we going to validate our shipping studies or validate our shipping mechanisms and ensure that we're getting it to people. Billing is another area. This is oftentimes, sometimes it's pharmacy benefit, sometimes it's medical benefit. Oftentimes these patients have secondaries, tertiaries, even quaternary payers that you'll be using to get these through, and this is going to be a key element in particular to differentiate yourself, but really even just for the table stakes of being in the business to have a clear path forward for the billing. Almost every specialty medication will require a prior authorization, so having teams or expertise around how to get that done and how to work with providers in order to get that piece done. And I touched on it earlier, but making sure that you've got the right clinical services. So do you have expert pharmacists on staff that can talk with these patients, can talk with these providers, but it's other staffing as well. As I mentioned, kind of prior authorizations and those things. You're probably going to need a team or at least a couple of people who that's what they're doing. You're probably going to have a shipping department, or again, at least a couple of people who are really well versed in shipping. So it's those clinical services, but it's a lot of the other services as well. Data reporting, which I mentioned, will be kind of the third bucket that I talk about. But really looking at can you extract data to get it to the various stakeholders that are looking at and looking for that data. And then really, I think customer service is another key here, is that because these are patients that a lot of pharmacies are really going after, are really trying to kind of woo and help them understand, the services that they provide that may be beneficial to that patient. This is an area, probably unlike any other in pharmacy, where you've really got to be able to knock it out of the park. The expectation from providers, the expectation from patients, the expectation from the health plans that might be hiring you to be their specialty pharmacy is that you're going to do this and you're going to do it very, very well. So just something that I wanted to at least mention, it's not something that you can, take for granted. And so then the last big area is kind of those resources that you need and the associated costs. So, an important thing again with specialty pharmacy, the margins and the gross margins are significantly different. I think, right, for a lot of us who have worked in healthcare, and even specifically in pharmacy, we're talking, low single to maybe mid single digit gross margins in this business. So this, this is something where, if the average price of a specialty medication is roughly $5,000 a month, I think everybody, the thought is that, gosh, the pharmacies must be getting rich because it's $5,000. Well, the reality is the net margin, without 340B or without other kind of purchasing arrangements is probably going to be, below 1% on that. And so when you start to think about those numbers, all of a sudden it makes these very high-cost drugs look a little bit different. And I think a mistake that a lot of health systems make is they run into this business because they see the $5,000 a prescription and they think, gosh, we're gonna be printing money doing this. It's gonna be a great service for our patients and we're gonna make a bunch of money on it. Because those gross margins are so small, it's a small percentage of a big number, so there's opportunity there, but there's also opportunity to get upside down pretty quick. So I talked earlier about shipping. As you can imagine, if you've got a 1 to 2% net margin on a $5,000 drug, if you miss ship 1 or 2, that wipes out your margin pretty quick for a whole bunch of other prescriptions. So just something, like I said, I think to think about differently, as just because, again, those percentages are so different than a lot of other areas in the healthcare system. And then I've already really talked about this, I think, but just the idea that staffing really looks a lot different. You kind of have to throw out the window any staffing grids you have for what your hospital pharmacy looks like, or again, if you have a retail or a discharge pharmacy, what it looks like. The staffing is substantially more robust. You're going to have a lot more FTEs kind of per patient or per orders than you might think about in other areas of pharmacy. And then just the additional operating expenses. So again, things that you may not think about with running a pharmacy. So I mentioned kind of cold chain and the delivery expenses. You're oftentimes also going to have a number of different data management or clinical management systems that you're using that will incur fees. Accreditation is something that will have fees. In fact, I know some of our accreditations are tens of thousands of dollars a year to hold those accreditations. And then, as we're going to talk about data, just kind of everything that needs to be done around data management, that a lot of pharmacies traditionally don't do a lot of work with extracting data or doing data management. So oftentimes an area that needs to be developed out or built out. All right, so some strategies to get started, so kind of getting into some of these opportunities and where they are. I think the first one is really the idea of just maintain the current environment, kind of leave things as they are. And oftentimes, that is the right choice. Again, I think a lot of people get stars in their eyes or, think about, gosh, specialty pharmacy is going to be a huge financial boost for us. But when they really start to run the numbers, oftentimes the right decision may be to do nothing. I think other things that people do to get started is partnering with an existing pharmacy. So instead of building out all of the services right at once, they might build out some of the services and rely on outsourcing to another for part of that. Or then ultimately, right, the other, kind of the all-in strategy is to actually start the pharmacy and build it out and do all the things that we've been talking about. Some of those opportunities to really get into bigger, larger patient volumes, larger patient populations. The first one is to really leverage what the hospital or health system has from a payer agreement perspective. And so what I mean with this is, oftentimes, as I talked about earlier, as at-risk payment models or value-based payment models are changing, this is really an opportunity for you as part of the health system to go to that health plan and say, hey, look, we can't be carved out for our specialty pharmacy patients. It's a huge expense. They're clinically complex patients. We need to be able to care for our own patients. And so that oftentimes will open the door. The other piece would be to look at exclusive payer relationships. So again, if you've got one of these local or regional payers and you can show that you do a really, really good job with your patients, another strategy is to say, why don't you let us take care of patients outside of our health system as well? I've talked about accreditation before, and I think in the past, to be honest, I should probably pull this out of this slide, because accreditation has really moved from something to open up a lot more opportunities to really becoming kind of commonplace, really to be in this business, you've got to have the accreditation. And I do think it'll be a requirement to open up some of the bigger ones. So again, if you're looking at becoming an exclusive, for example, you'd have to have that accreditation. But more and more, this is becoming something you really need out of the chute. And then the last opportunity for kind of opening up larger patient populations are to look at some of the limited distribution drugs. So Does your health system have a center of excellence, for example, where you may be, the University of Minnesota, I can use as an example, has a very, very well-known cystic fibrosis center. Well, we've been able to use that to our advantage because we have that expertise. We have providers on board that are experts, world-renowned experts in this area. We've developed pharmacists that are experts in this area. That has oftentimes helped us break down the door and actually get access for our patients or more broadly for some of these limited distribution drugs. All right, so you might be wondering at this point, and outside of maybe some of the finances that I've talked about, why doesn't every health system have a specialty pharmacy? And I think it's really four big things. And so the first one is the idea of competition that I talked about earlier. This is a highly concentrated market. People aren't getting out of this market. If anything, there's people rushing into this market. And so the competition is, oftentimes, Fortune 5, if not Fortune 10 companies that are really trying to hold on to these patients and hold on to this business. The second big one I hope is clear by now is kind of the fact that if you can't get access to adequate or a significant number of payer contracts and or limited distribution drugs, it may not make sense to build out all of the requirements that you need to run the pharmacy. If you're only going to be able to fill 1 out of every 10 prescriptions sent to you, for example, or 1 out of 10 prescriptions that are generated in your health system, it may not be the best idea to build out everything that you need for a specialty pharmacy, only to find out that you're going to have a very low return on that investment. I think one of the other big areas is really it's lack of experience, or quite honestly, it's lack of expertise. Health systems, traditionally do inpatient pharmacy very, very well. They've figured out ways to manage the cost of that business. They have figured out ways to be clinically superior in that area. But oftentimes, once a person leaves our facilities, it's not an area of expertise that we've got. And this isn't something that you can really just go to the director of pharmacy or the chief pharmacy officer and ask him or her to do it off the side of their desk, right? This is something that really needs, as I was talking about earlier, kind of that all-in strategy to really go after this and really have a fighting chance of being successful. And then I think the other thing that we've seen that really, kind of prevents or kind of kills the idea of a specialty pharmacy for a lot of health systems is, something that seems so simple, but just the idea around competing priorities, that there's 100 other things that the health system is working on. They might be building a new wing of the hospital. They may be expanding into a new clinical service line. They may be bringing on a new practice. Something over the last probably 5 to 10 years, implementing a new electronic medical record or making substantial changes to their electronic medical record. All of those things, and it's not just the dollars and cents, right? It's not just the capital need. It's not just, kind of the expertise. It's really the attention units. Can you get the C-suite engaged in it? Can you get the pharmacy department? Can you get your payer relations department? It really does, because it takes that kind of all-in approach. If you've got, 5, 10, 20 competing priorities, what we've seen is that oftentimes, the specialty pharmacy is something that gets pushed down to the bottom. Even if, we've seen health systems that have a $500 million to $1 billion opportunity from a revenue perspective, have tons of, clinically complex patients that they could be helping. And, they've got an external vendor that does it okay. And they just, again, because of those competing priorities, it's just not something that rises to the top to be taken on. So some key elements of success that I can definitely say we saw at Fairview and the University of Minnesota, but I would say more broadly, kind of what I've seen nationally for the health systems that have made this work and have made good inroads. They all have, and it's probably more than this as well, but they all have some combination of these key elements of success. And the first one is that health system support, that they've got a C-suite champion that, I've probably, said it 100 times already, is making this a system-wide initiative, not just a pharmacy initiative. I think there's also, it's kind of a catch-all, and I was trying to, as I was putting these together, think of a way to capture it. And really what I came up with was this idea of kind of an entrepreneurial or kind of a new business growth-oriented spirit or mindset. This isn't easy. There's a lot of competition in the marketplace, well-funded, well-resourced competitors. And so you've got to have a group that's really going after this saying, I know what the hurdles are, I know it's going to be an uphill battle, but we're going to make this work and it's going to be fun and we're going to have huge success by making this happen. All right, I'm not sure why I just advanced, but I'll see if I can make it go back. All right, there we go. Sorry about that. A couple of other things is provider buy-in, so making sure that your physicians, in particular your specialty physicians, are on board. They need to be able to see the value. They need to understand why having an insourced versus an outsourced specialty pharmacy is something that would be beneficial to them and more broadly to the health system and to their patients. Again, I've probably said it a million times, the payer contracts. One area specifically that I wanted to mention here is as more and more health systems are owning their own health plan, that's a great place to start because you've got kind of an instant patient base or an instant your first contract to get started into the business because that's such a hurdle or such a barrier to entry. And then I think it's the service level. So it kind of ties back to what I was talking about around customer service. One of the things we talk about in our organization all the time is no patient, no provider, no health plan, no manufacturer is going to work with us just because we have Fairview or the University of Minnesota in our name. We have to provide the absolute best service possible in the market. We have to be as good or better than all of those other competitors because we're smaller. And so if we want to get the attention of potential buyers, if we want to get the attention of providers and patients, we have to be at least as good and generally better than what's available in the marketplace. And then again, 340B, as I mentioned earlier, it so fundamentally changes the economics of what pharmacy looks like that you're much more likely to be successful if you've got at least some 340B covered entities in your system. And it doesn't necessarily mean that every prescription you're going to fill is 340B eligible, but to have at least some of that and to have a good working knowledge and understanding of that is going to be a key to make it successful. So I want to shift then into kind of the third area that's so important to this, and that's really the idea of data and how to use that to potentially launch the specialty pharmacy, to grow those opportunities. It's just such a key element in this space. And so I think for starters to really just think about the stakeholders for data really are no different than the stakeholders for your specialty pharmacy services. So you've definitely got patients who are going to be interested in elements of data that you've got providers and physicians, you've got the payers and health plans, and then in particular because of limited distribution networks and limited distribution drugs, and just because these medications are so expensive and tend to have small patient populations, the manufacturers oftentimes will be looking for data from the pharmacy as well. And so really I think about data as kind of three big buckets of data. You've kind of got your operational or service data, kind of that tactical, logistical, really how you run the pharmacy data. You've got financial data, and then you've got the clinical data. And what you'll present and all that will be different or will vary based on the variety of stakeholders. So what I thought I would do is just throw in some examples or kind of talk through a few of these. And so from an operational service, as I was saying, this is really, it kind of gets to that concept I was just talking about is you've got to provide the utmost service level. Well, any pharmacy can, walk into a physician's office or can walk into a health plan and say, we provide the best service for your patients. It's another thing to be able to start to prove that or really demonstrate that out. And some of these will be used as differentiators. Some of these will oftentimes even be contractual requirements as part of the specialty pharmacy contract that you have with a payer. And so some of the examples are some of the call center statistics. So how fast are you answering the phone? Can people get through to you? Error rates, and by error rates, that could be anything from kind of true medication errors to a delivery error to a billing error, right? They want to know that you're running things through the pharmacy efficiently, but also correctly. Time to fill and turnaround time is another thing that is not common in a lot of other areas of pharmacy, But this is something where a manufacturer, for example, might want to know that when a prescription comes into your pharmacy, how fast does a patient actually get it? How fast can they actually start that medication? That's a metric or a number that we've tended to be very, very good at in our pharmacy and get definitely a lot of positive responses from the manufacturers in particular on that. And then basic kind of, probably what's measured in every other spot in the health system is looking at patient satisfaction and truly being able to measure that down to the specialty pharmacy level, but oftentimes even down to, for the various stakeholders, a health plan will want to know, it's great that you've got a book of business. I want to know how my members are doing. So it's something to keep in mind. And so then I threw in a couple of examples here. So this would be something, for example, that we would provide to a payer customer, a payer stakeholder on a quarterly basis where, and again, a lot of these things would actually be contractual obligations that we need to do these things. So we'd be showing them, you can see on the metrics part, the number that's kind of below. So for abandonment rate, it's 5% or less. We would actually generally have to pay a penalty if we were above 5% abandonment rate, or if our average speed to answer got above 30 seconds, there's generally, penalties associated with that. And then, just some other service examples. These are some of our customer satisfaction numbers. So again, something that we want to make sure that we're showing to the various stakeholders so that it's not us just saying that we're really good at this, we're actually proving some of that out as well. From a financial perspective, again, it's things like, are we finding assistance for our members? That's something providers oftentimes want to know is, as financial toxicity starts to become a thing that's being talked about more and more in healthcare, what are we doing to help reduce that burden for the patient? And do we have any metrics or numbers to back that up? I can say this is definitely a number that we share with our providers, and something that they're very, very interested in is, what's the average out of pocket for patients, or what's the, total amount of, manufacturer assistance or grant or foundation funding that you've been able to get for patients. And then again, it gets down to things that are more tactical around, kind of cost for prescriptions or cost by a given category, for example. And then also sometimes what we're trying to show is cost avoidance. So are there plans or things that we have put in place that would really, I'm trying to think, it's basically, so how do we show that things that we put in place through utilization management strategies or other things that decrease the out-of-pocket, for example, for a health plan? So sorry, I missed a question. I'm going to just step back for a second. A question around provider buy-in, how we measure provider satisfaction with the programs, and if there's any industry standard tools. And so we've not really, or I've not seen a lot of industry standard tools. The National Association of Specialty Pharmacy is actually working on kind of bringing in pharmacies into a provider satisfaction survey. We do participate in that. Today, most of our provider satisfaction is a homegrown survey of every provider who's made a referral to our specialty pharmacy. It looks very, very much like a patient satisfaction survey, but we actually send it to the providers who send prescriptions or send orders into the pharmacy. So we are able to measure it, track it, and trend it very similar to the way that we do customer satisfaction. And that would be, quite honestly, in kind of the previous kind of that operational or service examples, that is, that's one of the metrics that we are using kind of constantly. All right. And then the last would be kind of the clinical examples. So clinical, a lot of times it's around adherence. So does the patient have the medication? It's hard to know if they're actually taking the medication, but at least do they have it? We measure things like adverse events. But then probably more importantly in this area, we try to, as much as possible, look for disease-specific outcomes that we can measure. So I'll share a couple of those examples. So this is a cystic fibrosis example where FEV1 is just a way to measure how people's lungs are working. And so that's something that we've tracked in our CF patients to try to show that, patients who are using our pharmacy, or in this case, this was something we were showing to a health plan we were working with, are doing appreciably better than the national average, and in fact, even better than the average that we were having at our own CF center. BMI, so weight gain, is also an important thing for CF patients. So this was another number that we were showing of just trying to show the number of patients that were actually achieving their goals. And as I mentioned, this is really something that it varies disease state by disease state. So what you might share for CF is different than what you'd show for MS or for rheumatoid arthritis. And then here's just another example around adherence. Again, just kind of sticking with the CF theme, that we've got some data showing that, at least from one published study, that we were appreciably better making sure that our patients had their medications. And then this last slide was just of examples. It's just kind of broadly some of the things that we measure in a variety of different therapeutic categories or disease states. So, medication possession ratio, looking at how much drug does the patient have, so kind of a surrogate for adherence, and then some of the specific clinical metrics that we actually look for in those various patient populations. And so some quick considerations for data, or things to think about with data, is, I hope it's become clear, is really to know who's your audience or who's your stakeholder. The information that we might provide to a physician's office, for example, might be very, very different than what we would provide to a manufacturer or to a health plan. And not that we would hide the data or change the data. I don't mean that between the stakeholders. More what I mean is just, are there things that you would emphasize potentially different based on the stakeholder? And so then the second big thing, and it came from the question around provider satisfaction. Unfortunately, in specialty pharmacy, there's not a lot of benchmark data to compare yourself. That's probably a rapidly growing area in specialty pharmacy, as a handful of groups are trying to develop some benchmarks so that you've got a sense of, even if you can measure something, is it any good, right? So if you've got a 90% patient satisfaction number, is that good, bad, or indifferent? So really trying to establish the benchmarks, but also not getting so wrapped up in, there's no benchmark, so I'm not going to measure it, that I think you've got to have some ideas to be able to really try to definitively, or at least objectively, prove what your value is. And one of the ways to do that is to look at, what are some of the competitors? Are there things out there that, Express Scripts Accredo or CVS Caremark or Prime Walgreens, if there's some things out there that they're reporting, that can sometimes give you an idea of what you may want to look at. And then a second big one is looking at, what are some of your differentiators? So if there's an area that you really think you excel at, or you're doing a really, really good job in, we'll measure things around that, so that you can not only, go to one of the stakeholders and say, hey, I think we're great at multiple sclerosis. If you've actually got some data to back that up, that's going to help. And then I think the other big consideration is kind of beginning with the end in mind. So if you know some of the things that you're ultimately going to want to show, to be thinking about, do you have that in one of your data systems in a discrete format that you can report on it, kind of all the things that hit on data in every other area besides specialty pharmacy, right? Every other area in healthcare. And then I think one of the last big things is this idea around if the data is significant. And what I mean by significant is not, is it important, but, right, could you publish it? Does it have a p-value of, less than 0.05? And I think it's important to think about, does it have to be? Because obviously, if you can do something that rises to that level, that's great. But with specialty, the patient populations are so small that oftentimes you're not going to be able to do something that's statistically significant. And I think what we have found is, to stay with CF, because I've shown a few examples, in cystic fibrosis, if you've got 10 CF patients with a given payer, and all 10 of them are doing better, 10 patients isn't enough to say that it's significant, but it's still something I would 100% report out to that payer, because they're going to want to know that, right? They want to hear that their patients are doing better. And I think the other thing to not forget about is, that sometimes the stories are also as important as, your statistically significant numbers. So I think back to when the hepatitis C medications were such a huge spend, and they were newer in the marketplace, and all the health plans that we worked with were, trying to figure out what they were going to do. And, we had all kinds of data showing how many patients we had using an 8-week versus a 12-week therapy, which is better for the payer because it's less expensive. We had all kinds of data showing, how many patients had been cured and what the side effect profiles looked like and all that. And the thing that I'll never forget, 6 months later, that a pharmacy director and a medical director remembered about that meeting was we told them a story about that a patient had dropped a $1,000 tablet of their hepatitis C medication under their refrigerator, and they called our call center to say, you know, gosh, can you replace that tablet? I know it's really important for me to take my therapy as prescribed. And our call center responded, you know, no, we can't replace the tablet, but we can absolutely send somebody over to move your refrigerator. It's $1,000. And so that had nothing to do really clinically. It wasn't a statistically significant, you know, piece of data that we presented, but that was something that they really, really remembered and just really thought of, wow, you had our best interest in mind. So I think that's something else to be thinking about is when you're thinking about data is, you know, there's kind of the hard data, but to not forget about some of that subjective data or some of the, you know, kind of anecdotes or stories that you can share with people. And so I hope it was helpful to share some of the data pieces because, as I said, I think to open up some of those opportunities that we talked about earlier, you know, to expand into potentially working exclusively with a payer or getting access to some of the limited distribution drugs, a lot of this data is the way that you're going to do that. And so I think with that, I'm going to finish up, you know, with, well, key takeaways. I've been going through these as we were talking. I think I want to make sure I leave some time for questions. So I think those last couple were really just further things that I was talking about around some of the challenges and takeaways with the data. So I'll send it back over to you guys to open it up if there's other questions.
Okay, thank you, Kyle. Thanks for sharing your knowledge and expertise on this topic, and we want to thank everyone for their participation and welcome any type of questions that people may have. Type them into the Q&A box on the right side of the screen, and we'll get through as many questions as we can, probably one or two with the time we have left.
Yeah.
All right, so I don't see any questions at the moment. So we want to, again, thank Kyle for taking time out of his busy schedule for providing this webinar. We want to thank everyone for participating in the webinar today. We want to encourage you all to complete the survey about this webinar that will be sent tomorrow. Your responses will help us identify future topics you'd like to hear about. And so we'd like to thank you again and hope you all have a great rest of the week. Thank you, Kyle.
Thanks, everyone.